Okay, good evening, everybody. So, my talk today is of positioning of sulfonylurea in the current era. Now, sulfonylurea has been there for a long period of time, but I'm sure, ladies and gentlemen, when I attend and you attend various programs, in various programs, whenever a new molecule comes up, the pet bashing boy becomes a sulfonylurea, and everybody tries to bash it. Although about close to half of all the prescriptions worldwide, not only in India and even in the USA, they contain sulfonylurea. So the concerns are efficacy, the beta cell exhaustion theory, the CB safety theory problem, the hypoglycemia, and of course the weight gain. So I'll tackle it one by one. So I'll give you some hypothetical cases and what I would have done in 1990, and by me I mean majority of the doctors, and what I would do in 2023. So if we have a 50-year, we go back in the past. So 50-year-old with tiredness, newly diagnosed diabetes, 150 fasting, 270 pph, HbA1c 8.5. Now, this is my old photographs, the 1990. So what would we do then? We will start on diet. We may consider metformin. And then we have this attitude of then, let's see for another 3 months. Let's see what happens. Let's see what happens. Just a single drug first, then escalate the dose, then go to the second drug. That's what we would have done in 1990. But now, this is my more recent photograph, 2023. So what would you do now? We do now what I would do now. So I would not only start this patient on metformin, but I will give a cocktail of other drugs as well. So multi-pronged approach. So DPP4, consider DPP4, and as the situation demands, SGLT2 inhibitor or pioglitazone or both. And I might also consider a low-dose sulfonylurea. The theory is hit hard, hit early. So you have to hit hard and hit early. So why this hit hard, hit early? And this is classically brought out by this model made by Rudy Holman based on the UKPDS data. So what they modeled was a 50-year-old male with newly diagnosed type 2 diabetes. If you leave it at 8% for 10 years, and then reduce it to 7% for the next 10 years, you have a reduction of death by 6.6%. You're still doing some good by reducing the HbA1c. But if you straight away reduce it from 8 to 7% right at the diagnosis, then you increase it, the reduction by threefold. So it's always important now that we hit hard right at the beginning. And the most efficacious agent, or one of the most efficacious agents, are the sulfonylureas. The efficacy is much more than the DPP4 inhibitors or the SGLT2 inhibitors or the alpha glucosidase inhibitors, even metformin. So it is one of the highest, one of the very high efficacy anti-hyperglycemic drugs which is available. So now the other thing in the past we would worry is, oh, you want to start one of the most right at the beginning. If you start it, won't you exhaust the beta cell? Won't the patient be exposed to insulin quite earlier rather than later? So let us examine this, because this is often quoted and often thrust down our throat. I might add. So if you look at the UKPDS data, so here this is the HbA1c. It's after the HbA1c coming down with all the therapies. Now there is a Nike sign, it goes up. So why put the blame only on the sulfonylurea? So glimenclamide and chlorpropamide are the green and the blue. There the tick is going up. But the tick is going up for metformin also, for insulin also, for the conventional arm also. So why are we picking up only on the sulfonylurea? Now if you look at the UKPDS data again, so where they measured the beta cell function over the first 6 years. For the first 6 years, they had HOMA estimates of beta cell function. And the yellow is the sulfonylurea, and the red is the conventional, and the blue is the metformin. So if you look at the non-good people, when you give the sulfonylurea, beta cell function improves. And then it begins to drop. But see, the difference between the conventional arm is the same. So at 6 years, there is still a difference between the sulfonylurea and the conventional. It is not that this curve is straight down like this, that after 3 years, the beta cell function drops drastically and it goes much below conventional arm. No, It still stays above conventional norm. It drops parallelly. And in the overweight, same. It drops parallelly to metformin also. Okay. So therefore, this finding refutes a widely held view that sulfonylurea will stress beta cell by increasing insulin secretory demand. So this one slide clearly shows that. Now, the other one, the great study wherein patients on metformin were divided into four. So sulfonylurea, which was glimepiride, sitagliptin, liraglutide, and glargine. So four groups of drugs. But the primary endpoint was time to HbA1c of more than 7%. So basically, which drug fails first? So the longer the time, the better the drug which they are holding on to the beta cells. Now, if you look here, so liraglutide is the winner, 882 days, and followed closely by insulin, 861 days. But glimepiride is not that far off. It is 810 days. And way behind is DPP4 inhibitor, 697. Then we keep hearing that, oh, DPP4 inhibitors, they preserve the beta cells or sulfin because they are much better than the sulfonylureas. Here we have got a big proof, head-to-head comparison, which shows that the glimepiride tends to not fail for a much longer period than the DPP4 inhibitors. So in the ADAPT trial, as you know, the thiazolidines are the group of agents which has got the maximal effect in preventing onset of insulin treatment. So here they evaluated rosiglitazone, metformin, rosiglitazone in blue, metformin in green, and the sulfonylurea in red. So again, beta cell function over 5 years. Beta cell function goes up initially, it comes down, but it's still better than the other two even at the end of 5 years. So why is this beta cell exhaustion theory still in place? The TOSCA IT trial, so it was a multi-center randomized trial where the patients were divided into, patients on metformin were divided into either pioglitazone or a sulfonylurea. Okay, and here again you can see the sulfonylurea and the pioglitazone, the HbA1c, it is the same at 5 years. So it is not dropping, not going behind any of them. Now, if I change the case a little bit, and if I put higher values of the fasting PP and the HbA1c, in the past, 1990, I would think of metformin, sulfonylurea, and probably think of insulin at this stage. But now, no, I would still say, let us put I might still say, this is newly diagnosed diabetes. This patient is not 20 years diabetes, newly diagnosed. So I might say now that why, if there is catabolic state, is weight loss, more than 5% weight loss, or clear, very bad osmotic symptoms, polyuria, polydipsia, any infection, but all these reasons, and insulin, of course, no question. But why insulin if these are not there? There's ample data to suggest that these newly diagnosed diabetes patients, you can bring it down nicely without causing hypoglycemia. So why not add metformin, sulfonylurea, DPP4, pioglitazone, any combination of these or all of them together? So as I said, sulfonylurea has got the highest concentration. So I wanted to dig up into the ADA, and you can see here in ADA 2022, there was this data. You can see here that in patients with HbA1c of more than 10% or glucose levels more than 300, they have said insulin. But it is also written there. However, there is evidence that patients with uncontrolled hyperglycemia associated with type 2 diabetes can also be effectively treated with a sulfonylurea. And see this reference 51. So I dug up that reference. A very funny study, really, because I don't know how it passed ethical approval. So what they did was simple and safe and simple emergency treatment discharge for patients with type 2 diabetes and severe hyperglycememia. What they said is that, yes, although most of the guidelines say more than 300 you start insulin, but in our busy emergency department, it is very difficult to start insulin therapy. So we end up starting oral sulfonylurea. But we wanted to say, just by starting oral sulfonylurea in this phase of this high blood sugar level, are we able to bring it down? So what they did, patients with type 2 diabetes who are presented with sugar levels of between 300 to 500. You were in two groups, glipizide 10 milligram, G group, glipizide plus glargine, G plus D group. And what they found was that the success rate for both was similar, and blood glucose levels had come down nicely. The glargine group were statistically not significantly, slightly better than achieving their fasting or pre-meal goals of 80 to 130. But what it suggests is that this, what they have said, this is the first report to indicate that even during severe hyperglycemia, the beta cell retained the capacity to respond to the sulfonylurea stimulation. Now, the commonest sulfonylurea combination you can see from this study is that the 44% of the patients, of the doctors prescribed glimepiride 2 plus metformin. But you see, in newly diagnosed diabetes, high blood sugar levels, I've seen many prescriptions where glimepiride 4 milligrams has been started right at the beginning. Why? I just start with 0.5 of the glimepiride in most instances, because in many patients, it comes down nicely with it. So somebody is having a blood sugar of 400, it comes down to 150, they begin to feel unwell if you bring it down very quickly. So what is the rush if there is no compelling indication? There's no rush. Bring it down slowly. So I normally start with 0.5 of sulfonylurea right at of glimepiride. Say, for example, if I start with sulfonylurea right at the beginning, along with the other medications which are also there, which is metformin, DPP4, pioglitazone, or SGLT2 as the situation demands. I start with 0.5 of glimepiride, see the patient in 10 to 14 days, then slowly begins to come down nicely, and slowly the patients don't feel that unwell. And at the end of 1 month, it settles down nicely. If there's no response, of course, I will escalate at the end of 1 week. Now, I change the slide and make that patient has had an MI 3 months ago. So type 2 diabetes, now it's no longer newly diagnosed. Type 2 for 2 years on metformin plus DPP4, MI 3 months ago. So this is the fasting bean HbA1c. So in the past, we would say sulfonylurea, no, CV risk problem. We'll always give insulin. But now SGLT2 must. Why not sulfonylurea? So in the UKPDS 44-year-old data, you can see with the sulfonylurea in red, you have 15% reduction at the end of 44 years. And of course, microvascular disease is even better, and with 11% reduction in mortality, all statistically significant. In the great study which I mentioned here, this is the 3-point MACE, and you can see that the glimepiride is better than glargine insulin and sitagliptin as far as 3-point MACE is concerned. And even for the hospitalization due to heart failure, it is at par with the DPP4 inhibitors as well. In the advanced trial, where reduction of blood sugar was achieved with gliclazide over a period of 5 years, there also you see reduction if you combine macro and microvascular events, although the reduction was mainly due to the microvascular. Carolina, where you compared glimepiride with linagliptin, it's all in the center, 3-point and 4-point. And in fact, if you look at the patients with history of CVD, without history of CVD, elderly less than 70 years or elderly more than 70 years, everywhere it is right in the middle. And in fact, the heart failure was numerically better than even linagliptin. So I think the summary of key points that I would like to make is that the arguments previously was do not use sulfonylurea second line because of hypoglycemia. That remains. That problem remains, and I'm not shying away from it. It is there. So we have to be judicious, choosing the patients correctly, starting with a very low dose to begin with in newly diagnosed. That mistake is made, the hypoglycemia occurs initially because you start with a very high dose, start with a low dose. And sulfonylurea causing weight gain. It is a problem in the Western world, but having practiced in both hemispheres, I can tell you that the sulfonylurea weight gain in India is not that much, is not that big of a problem really as compared to the Western bit. So pioglitazone, there was mentioned, better durability of neoregens versus sulfonylurea, but no proof now. We have got the great study which doesn't suggest that. You have got, I've showed you the trials with comparing with thiazolidine where it didn't show better durability. So the points in favor are The randomization did not worsen long-term CV outcomes in the UK PDS. Metformin and sulfonylurea did not impair long-term CV outcomes in the UK PDS. Risk of hypo is well understood, should not preclude their use. Weight gain is modest, and newer agents have incompletely understood safety profiles. With that, I end. Thank you.